You are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, today we treat that of Erb's palsy or Erb-Duchenne palsy. My friends, whenever we talk about the Erb's palsy, then it reminds us that as far as the trunks of the brachial plexus is concerned, the one which is commonly, injured is of course the upper trunk. And so whenever we talk about this Erb's palsy, it has to deal with, of course, injury to the upper trunk of the brachial plexus. And so whenever we talk about upper trunk of the brachial plexus, then the root value, will be C5, C6. Now, importantly, one thing that we are aware is that we have something called an Erb's point. Okay, I'll be coming to the clinical point. Whenever we talk about Erb's point, we know that 6 nerves, are involved over there or are meeting over there. And so that is why we'll be having what we call the C5 root, we'll be having the C6 root. Yes, of course, we'll be having what we call the anterior and of course the posterior divisions of the upper trunk. And of course, the 2 nerves which will emerge from the upper trunk of the brachial plexus by way of what we call the suprascapular nerve and of course the nerve to subclavius muscle. Okay, so these are the areas, with the nerves which are involved at the Erb's point. So that's the area where of course this injury is going to take place. Now, when we look at Erb's palsy, one important thing which I want you to become aware is that is due to something we call downward traction of the upper trunk of the brachial plexus. When there's that kind of sudden downward traction, as far as the upper trunk of the brachial plexus is concerned, then the injury that is most likely going to take place is of course injury to the upper trunk, which will manifest as the Erb's palsy. Now, importantly, what could be the risk factors? What could be the predisposing or the causes of this Erb's palsy? One important thing which often everyone is aware is of course inadequate or unprofessional delivery, as far as delivering the fetus from the birth canal of the mother is concerned. And so what are some of these things? One of the things which can lead to this kind of poor delivery is something we call shoulder dystocia. And so in shoulder dystocia, what we find is that the fetus's shoulder is trapped behind the mother's pubic bone of the pelvis. And so if the health professional tries to pull and of course bring out the shoulder and all that, there could be that kind of injury, there could be that kind of downward traction to the upper trunk of the brachial plexus. That is why importantly we need to understand that there could be some indications for something we call cesarean section. Because sometimes if the fetus is so large, in situation of macrosomia, then there may be the need that you don't go through the vagina naturally. Per vagina may not be indicated. So these are some of the things which I want you to understand. There could also be a situation that of course it could be even a normal delivery, but of course the health professional tries to pull or twist the head laterally and all that. It can lead to downward traction to the upper trunk of the brachial plexus. There could be that kind of breech birth also, where of course the fetus comes with of course the limbs, the lower limb I'm talking about, and therefore and then tries to pull it and all that. It could lead to downward traction to the upper trunk of the brachial plexus. Now, the important thing I want to make out over here is that according to the American Academy of Orthopedic Surgeons, 1 in about 1,000, live birth, results in what we call Erb's palsy, may have Erb's palsy. But my friends, there's a good news. The good news is that in about a year, if you go through that kind of proper treatment, then what will happen is that 80%, at least 80% of them will recover. And even the recovery may even improve if treatment commences within the first month of delivery. So these are the good news that we have. So I'm going to tell you about all these clinical signs and symptoms and all that. But the important thing I want you to understand is that there's a hope. So one thing that I want to also bring out over here is that if the mother is having, let's say, gestational diabetes, it may result in this macrosomia that I'm talking about. If the mother is obese, then it may give birth to some of these, macrosomic, babies. And for this reason, there may be the need for what we call cesarean section. Now, enough of all those things. We are looking at the anatomy of clinical importance. Now, if we talk about Erb's palsy, then what are the things? What will be the manifestation of this Erb's palsy? One important thing which I want to bring out over here is that, yes, we ask you what will be the attitude of the patient, of this newborn, okay, as far as the Erb's palsy is concerned. What is the clinical manifestation? What's the simplest thing that we're going to say? It's something that we call it policeman tip deformity. Policeman tip deformity. Something we can also say waiter's tip deformity. Yes, or the porter's tip deformity. Now, what do we mean by this? Now, I'm going to do it, and of course, we are going to go through it. So, if you can look at what I'm doing, okay, this is how this Erb's palsy, yes, or clinically, yes, presents itself. And so, let's go through, the presentation I'm talking about. First of all, the upper limb, as far as the shoulder joint is concerned, will go into a state of adduction. Yes, adduction. So this is what you saw, adduction. As far as the shoulder joint is concerned, yes, the upper limb will go into a state of adduction. I'm talking about adduction. Adding it, bring it closer to the midline of the body. Now, why is it so? Because of the unopposed action of the adductors. Yes, that is why it results in adduction. Okay, so it means that what are the muscles which are supposed to rather have caused abduction at the shoulder joint? And so one important thing which I want you to understand. Now remember that I told you that as far as the brachial plexus is concerned, it's happening to the upper trunk of the brachial plexus. And we said that the upper trunk of the brachial plexus, the root value is C5, C6. Now as far as, the abductors are concerned, oftentimes I've mentioned this severally, that one of the abductors, as far as the upper limb is concerned at the shoulder joint, yes, is what we call the supraspinatus muscle. Supraspinatus muscle. We said that supraspinatus muscle is responsible for the initiation of abduction, 0 to 15 degrees abduction. And remember that supraspinatus muscle is supplied by, of course, the suprascapular nerve. Okay, so that's one thing I want you to know. And it's also going to have root value C5, C6. So whenever the upper triangle is concerned, then the fibers C5, C6, which are supposed to give supply to, of course, the supraspinatus muscle, will not be there, and therefore you cannot initiate abduction. My friends, even propagation of abduction beyond 15 degrees up to about 90 degrees will be lost. Why? Because we know that the deltoid muscle, yes, important, I'm talking about the middle fibers of deltoid, is responsible for, of course, the remaining 15 to 90 degrees abduction. And my friends, the deltoid muscle is having a sole musculature, okay, by way of innervation coming from, of course, the axillary nerve. And so if axillary nerve, its root value is what? Is C5, C6. Yes, that's why we are going to have, these things that I'm talking about. Okay, so that is important that we understand. So the movement that will be lost, one of them is, of course, this, abduction at the shoulder joint. And so the patient will go into a state of it will be abducted. The upper limb will be abducted at the shoulder joint. Now the next thing that will happen is not only abduction which will take place at the shoulder joint, but also medial rotation. Something you can also call it internal rotation. Medial rotation or now going this way is external rotation. This is medial or internal rotation of the upper limb at the shoulder joint. Now the question is why? Because of the unopposed action by what we call the external or the lateral rotators. And so then the point is that which muscles are involved over here? Which muscles are not getting nerve supply? Okay, so now first thing, what are the muscles which are responsible for what we call external rotation? Okay, what are the muscles responsible for that? And one of the muscles responsible for external rotation is, of course, infraspinatus muscle. And remember, infraspinatus muscle, just like supraspinatus muscle, is also supplied by what we call the suprascapular nerve, C5, C6. Okay, not only that, even the teres minor muscle. Yes, teres minor muscle, yes, is also responsible for lateral rotation of the upper limb at the shoulder joint. And remember, teres minor muscle, just like deltoid muscle, is supplied by, of course, the axillary nerve, C5, C6. And therefore, that one will also be lost. And so the upper limb goes into a state of internal rotation. Not only adduction, but also internal rotation. Now, apart from that, what we see is that the upper limb, as far as the elbow joint is concerned, will go into a state of extension. It will go into a state of extension. It cannot be flexed. It goes into a state of extension. And so it tells you that which muscles, okay, are involved. The extensors are working all right, okay, triceps and whatever, they are working all right. But of course, as far as the flexors are concerned, that's why you cannot flex. And so which muscles are involved? You know that the muscles which are responsible for flexion, yes, will be, of course, we talk about the bicep brachii muscle, and then deep to it, we talk about brachialis muscle. Okay, brachialis muscle will also be affected. Okay, now what's the reason? Now the reason is simple. I mean, we know that as far as, yes, the upper limb is concerned at the arm, we know that these BBC muscles, even including coracobrachialis muscle, we are not going into that one. I'm talking about the brachialis, and then of course the bicep brachii muscle. They are supplied by, of course, the musculocutaneous nerve. Now, one will say that musculocutaneous nerve, yes, the root value is C5, C6, okay, and of course C7. My friends, one thing I want to tell you is that as far as, you know, the musculature to the bicep brachii muscle, of course, the brachialis muscle, yeah, the fibers C5, C6, they are doing that, okay, and that is why we may not be able to flex. Yes, you may not be able to flex. Okay, that's what is going to happen. So the upper limb goes, as far as the elbow joint is concerned, goes into a state of what we call extension. That is that one. Now, what else happens? Now, the other thing that happens, okay, is that, as far as the forearm is concerned, yes, also, yes, working at this, joint over here, radiocarpal joint. As far as the forearm is concerned, I'm talking about radio ulnar joint. What happens is that we will see the upper limb, okay, will go into a state of pronation. Yes, it will go into a state of pronation. Okay, not spination, I'm talking about pronation. That is what is going to happen. Now, what it means is that the spinators are not working. That is why the unopposed action of the pronators, yes, is making the whole thing dominant. And so the upper limb goes into a state, as far as the forearm is concerned, goes into a state of pronation. Why? The reason is simple. Because the biceps brachii muscle is not only responsible for flexion at the of the upper limb at the elbow joint, but my friends, it is also responsible for what you call supination. And also the muscle, which we call a supinator muscle, the fibers, yes, it's not getting that supply, and therefore upper limb goes into a state of pronation. That is one thing I want you to know. Now, that is not the only thing, because what we see is that in Erb's palsy, we see that the upper limb, this time around, at the level of the wrist joint and at the level of the fingers, will drop. Okay, so there will be flexion. Okay, palmar flexion, let me put it that way, as far as the wrist joint is concerned. Palmar flexion, so there will be wrist drop, and then also there will be finger drop also. Okay, now this time, we talk about these, extensions of the wrist and of course the fingers, okay, to be supplied by, the radial nerve. Okay, the fibers responsible for, causing flexion, causing extension this time around, causing extension as far as the wrist joint and then of course the fingers are concerned is by the fiber C5, C6. And so because there's injury to the upper triangular brachial plexus and therefore C5, C6, okay, the fibers are no longer working, then what's going to happen is that, yes, it's going to lead to what we call wrist drop and of course finger drop. So in Erb's palsy, Erb-Duchenne palsy, you also be seeing finger drop, you'll be seeing wrist drop. So overall, what movements, yes, are lost? And that is why simply there's a mnemonic I use for that, FICE movement. And FICE movement, I'm talking about flexion. Yes, you cannot flex the upper limb at the shoulder joint. And then of course, A is for abduction. You cannot abduct at the upper limb at the shoulder joint. Okay, and then of course, E is for what we call external rotation. External rotation is not possible because of internal rotation. Yeah, it's not possible, FICE. And then S, we're talking about supination. It's not possible because they're going to be pronation. But not only that, we need to think about what happens to the wrist and of course the fingers. That there will be finger drop and of course wrist drop. So it's like a policeman trying to take a tip, yes, from a driver who has committed an offense, or a porter, yes, taking a tip from someone, or a waiter trying to take, if you are a waiter, you're not supposed to take things from customers. Yes, but you can take it using that way. So waiter's tip, porter's tip, and of course policeman tip deformity. My friends, is that all? No. There's one. All these things I was talking about, yes, they are muscle. We are talking about motor movement. Okay, movement, muscles lost, and all that. But is there any other cutaneous or sensory loss, my friends? That the answer is yes. Yes. Because one thing that we understand is that as far as the dermatomes of the upper limb is concerned, C5 and C6 will be supplying the lateral aspect. So C5, okay, and then C6 all the way towards where the thumb is. So this baby, the newborn, okay, the neonate will not have sensory loss as far as the lateral aspect, okay, of the upper limb, yes, is concerned. Towards where the thumb is. Okay, so these are the things which I want you to understand, okay, as far as the Erb's palsy is concerned. My friends, I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.